And next, introducing Dr. Ros Taylor, who I work with here at Michael Sobell House, my brilliant boss. Many of you know Ros, who has been a palliative care doctor for 33 years. She has a curiosity for new ideas in palliative care from around the world, and she's going to share some of these discoveries with us.
Thank you, everybody. It's been great fun putting this conference together, and I want to thank all the speakers. I only invited people who I've heard before, and that includes me, so there we are. So, yes, I have been curious, probably my whole career, about what could we learn from elsewhere in the world. So I'm going to whiz through some things that I hope will inspire you to read a bit more, think a bit more, how could they apply in your practice, or what could we do locally in our system. So, I hate to tell you, but you all work within a system, and this is a diagram of the death system, which we developed when I, and actually Sarah, we were working on the Lancet Commission on the value of death. So, you can't see the detail of this system, but you all work within it, and we can make changes at any point. So you can look at this slide when we send them round and decide where you're going to make a difference. So innovation, these could be clinical, they could be technological, pharmacological, community-based innovations, and of course, we can change the law. So, first of all, system innovation. Many of you know that from Michael Sobell, we ran a series of ECHO tele-mentoring systems last year with London Ambulance Service. So tele-mentoring, or Project ECHO, is the idea that specialists, and there are many specialists in the room here, do not have time to teach and see everybody who might benefit. So how could we use Zoom or Teams to spread our knowledge? And so this is a really simple idea, and it's been developed in America way before COVID, when we all became familiar with Zoom and Teams. So the idea is you have a specialist hub, and you connect with all of the people who want to know more about what you do. Simple idea, but we don't do it enough. We heard before, I think, from Zena about FaceTiming 7,000 people to help with the problem of incontinence. So we need to use all of the digital tools at our disposal. The Serious Illness Conversation Guide is also something I'm very interested in. We are constantly thinking, how can we perfect our conversations with our seriously ill patients? This, again, it's been developed by Dr. Atul Gawande. Most of you will have heard of him and will know of his book called Being Mortal. But this is a very simple, relevant conversation guide which is being researched or piloted in many hospitals in the UK, mainly in our cancer centres. But just giving you really simple clues about how to speak to people where you know, we have a crystal ball in our head. We do not know what will happen to our patients, but we know what might happen. And I think the sharing of what might happen is something we're very bad at. But that gives people reassurance to plan ahead. What else? Dignity therapy, I think that was just mentioned. This is just a very structured way of capturing people's life story. I've got the QR codes on all these slides so you can look up more, but I'm just giving you a taster of what has inspired me over the years. Dignity therapy is just very brief psychotherapy to capture your life story and what you want to share or be shared after you die. And we know that talking about your life is much more interesting than talking about your bowels. So people do want to share their story. They do not want to spend their whole time talking about their symptoms, which is what we predominantly do. Now, palliative sedation is going to come into focus as we talk more about assisted dying, whether the law changes on Friday or not. And the Dutch have developed a really good guideline relating to palliative sedation, and I urge you to look at it. It is translated, luckily, into English, and the QR code takes you to some really good guidelines, and I think we all need, all of us who are working in palliative care need to develop our palliative sedation guidelines, because obviously palliative sedation is very different from assisting somebody to end their life. But sometimes we need it, but being able to talk confidently about the difference between palliative sedation and euthanasia or assisted dying. And they have a great, you can't see this, but they have a great infographic which reminds us about how to talk about palliative sedation with families. What else? Namaste care. Those of you, and I know we've got guests today who work in care homes who will be more familiar with Namaste. Namaste, I think, means welcome, possibly. Anybody correct me? But it's a way of stimulating the senses of somebody often with advanced dementia, but I think we could use it with delirium as well. So stimulating hearing, smell, touch in very gentle ways. And I know the care home that we heard from this morning, wherever Karen is, use Namaste a lot. There's a Namaste program encouraged for every resident. And you see extraordinary results of people starting to communicate again, whether it's just through stroking a soft toy. It somehow stimulates the senses, which might stimulate the memory, which might stimulate cognition. So namaste. So still talking about communities, and just to say that many of the photos here are of patients we've cared for. This is not a patient who's in Kerala. It was a patient we looked after here at the hospice, but we have consent for all of the photos. But many of you will have heard of the Kerala Neighbourhood Network of Palliative Care. It really is extraordinary. They have mobilized, I think, up to between 10 and 20,000 community volunteers to support people who are dying in the community. These will be policemen, teachers, just ordinary people who want to support a neighbour or somebody in their community with a deteriorating illness. It is a WHO heritage project, and it's something we could learn from. It may not be scalable exactly to the UK. Some of you will have heard of Compassionate Neighbours, which is a project similar, but I think we could learn so much from Kerala. And this is from Argentina, from Buenos Aires, where there was very poor palliative care for a long time, but the right to palliative care has been enshrined in law in Buenos Aires, I presume the whole of Argentina, and it's particularly focused on palliative care in primary care. And I had an email from a colleague in the room who's here today who said that we've seen so much disengagement from palliative care in primary care in the UK, which is a tragedy, because I started life as a GP, and that's what inspired my interest in palliative care. So we could learn from Buenos Aires. So, talking about technological advances, again, India is leading the way in health tech. It really is. I think in India there are more mobiles per person than anywhere else in the world. So, Indian healthcare systems have cashed in on this and make sure that key health messages like early signs of cancer, they are communicated widely to everybody's mobile phone. We ignore most of our messages in the UK, but if only we use them for good and use them to... Everybody's getting very hot. I will speak more quickly. Yes, so mobile health apps, using our mobile phones more creatively. This is an Indian app that is widely used by palliative care teams in India called Palliative. I haven't looked at it in detail, but it's really simple and it's aimed at families caring for people at home. Palliative, I think we can actually log on and it's free to use. Pain check. This is really extraordinary. You take a lot of pictures of somebody's face when they're in pain, and AI will then tell you whether that person is in pain at a later date. So for people who are non-verbal or who can't tell you that they're in pain because of cognitive impairment, you can tell by facial recognition from their grimaces, from their frowns, from the way they're using their mouth that they're in pain. So this is Pain Check, and this is available in the UK. Now, we have used in the past virtual reality a lot in the hospice. It's gone quiet at the moment, but this is Yvette, who actually got married in the hospice 2 years ago. But we took her back to Barbados, where she grew up, and it was incredibly moving. She started crying because she could feel the sand on her feet. She could see the house she grew up in. And it was moving, but also incredibly therapeutic. And it's getting easier and easier to use. We've taken a 96-year-old to Lake Louise, where she got engaged to her husband. That is a beautiful blue lake in Canada. I think some people here have been to Lake Louise. I don't know whether you're waving at me or you're fanning, but anyway, thank you. So that's virtual reality. And then just a few examples of what's going on in the UK for different communities who we are not fully engaged with often. I know that there's a huge homeless problem in Harlington, a refugee problem, asylum seekers, and how engaged are we? St Anne's in Manchester has developed an extraordinary homeless service. They have 2 CNSs, clinical nurse specialists, who are employed by the hospice, who have engaged with local local hostels and homeless teams, and are making a huge difference. And you can read all about their service via the QR code. I'm giving you lots of homework. Virtual wards. Virtual wards are patchy around the UK, but I think using Zoom, using the telephone, why can't we just support people on a more regular basis by using Zoom or Teams or whatever works for that patient? I use FaceTime quite a lot now to talk to patients at home. We shouldn't be so scared about this communication. It's no different from phoning somebody up and talking. A lot of those calls were recorded, and a lot of this is recorded, but with consent, it's safe. So high-intensity virtual ward, Compton Hospice in Wolverhampton has developed a really, really impressive protocol for their virtual ward, and I would love to copy that in Harlington. Paramedics are being used much more in palliative care. I don't know if anybody here is using paramedics in their service. I think this is St Helena's in Colchester. They did a pilot with the East of England ambulance service and are now employing paramedics as part of their community team. Paramedics are trained to save life, but in a way, I think in palliative care, we save life. That's not about stopping people from dying, but we're restoring life in a way that Sarah restored life to her patient in Portsmouth. And we all have different skills, and we can use them differently. So it's great working with paramedics. Isle of Wight, Mountbatten Hospice is another hospice that I'm a big fan of. They've developed an amazing community van, looking at community engagement, attracting volunteers, giving clinical advice, and they have an extraordinary van that goes out to church halls, to libraries, and again, this is something we could all do. There are lots of funds that will fund a vehicle like this. So you might see something like that wandering around Harlington at some stage. Right, just coming to the close in a few minutes. I haven't mentioned many drugs. We've heard a lot about drugs in this morning. So 2 innovations I've learned of in the last couple of months. We had a patient with a terrible wound that wouldn't stop bleeding. It was really traumatic. It was around her neck. She had young children. We wanted to stop the bleeding because it was causing terror, not just in the patient and her family, but in us. So all the usual things that we use to stop bleeding with topical adrenaline and topical tranexamic acid didn't work. So we went along to Amazon and Googled hemostasis, and it came up with a marvelous spray, which apparently emergency medics use all the time, but we didn't know about it in the hospice. So we ordered 10 cans of this spray, and it worked amazingly. We've got some nurses in the room here who I think were used to using it. So every time the dressing was changed, every time there was some bleeding, spray, and the bleeding stopped. So there we are. And using crushed ice for nausea, I learned that when I visited a hospice in Denmark. If you cool down what you're eating and drinking, whether it's an ice lolly or ice in a drink or crushed ice, it blocks some nervous messages from our brain that stimulate nausea. So crushed ice for nausea. And in this hospice in Denmark, every room had a crushed ice machine. So something to learn from. And I think that would be really useful today. The only drug I'm going to mention, which sadly is not available for our patients, is psilocybin, magic mushrooms. Nobody's going to own up here to ever having tried or cooked a mushroom omelette with these, but psilocybin is getting huge interest around the world. It's a psychedelic drug, but the idea is that it can help with some of the existential anxiety and dread that we see in many of our patients. And it's being used in Canada for end-of-life patients and around the world. It is being researched in the UK, but we are the most over-regulated country in the world. Everybody would agree with that. And I think it's going to be years before we can use psilocybin, but watch this space. I can't read that without my glasses. This is a patient's quote. Just felt better after however he was treated with magic mushrooms. I'm going to mention HPAL. I've mentioned HPAL many times to many of you. It's a website that I've developed together with my colleague, Dr. Poppy Freeman, who's somewhere in the audience. Can you put up your hand, Poppy, wherever you are? Sorry?
Poppy's had to leave.
Oh, okay. So the website is up there. We've now got a NHS version, soon to be across northwest London, maybe north central London, and there is an NHS version in Essex. It will give you all you need to know in 5 minutes about any symptom that you might see, and we are developing it more broadly than symptoms. It's about conversations, it's about finances, it's about supporting carers. And the key thing about HPAL is that there's a portal for clinicians, but also a portal for patients and families. So do sign up to the newsletter, which is on the homepage. Just put your email in and you will get our updated articles. Okay, these are just a few very local projects to me. I am very interested, I don't want to put you out of a job, but I'm very interested in no needles at the end of life. I don't think we should be relying on district nurses to go out and give a morphine injection and for patients to have to wait. And there are almost no other countries in the world that rely on people going out to give injections. I remember I was inspired by this by a nurse who works in California for a home hospice team. She said, no, we don't go out and give morphine and midazolam injections. We either teach families how to do it, which is one way, or we use high concentrations of medicines, we use patches, we use things that melt on the tongue, and I'm very keen to develop a protocol which we could pilot locally. And we have all these drugs available. So anybody interested in the needle-free approach, we've developed a task force locally, and we're going to carry on looking at this. I had a Zoom, it's over a year ago now, with the Mayo Clinic Hospice at Home team in Minnesota. They look after 200 patients at any one time. They said usually over the course of a year, they have 2 or 3 people who need a syringe pump, very few people who need injections. I've got the protocol of what they do. It's very simple, and I think we could look at that. So to ensure that more people at home have a better ending. Right, we're coming to the end. Grief bots. So anybody here a fan of Black Mirror? Me? Okay. A lot of things that have happened in Black Mirror over the last few years are coming true. So I do recommend that you watch it. So the idea, well, grief bots are literally AI companions in your grief to support you, but perhaps slightly more disturbing is an app called, I think it's called Hereafter, it's down the bottom right of the screen, where the idea is that you capture everything digital, I'm just thinking of James here, that your loved one has ever done, all of their WhatsApps, all of their texts, all of their emails, all of their blogs, and it's all fed into an AI machine, and then the person, the dead person, responds to you as if they were alive. So there's something to think about. It's really popular in China and in the States. So that picture is a young man talking to his dead mother. So they've also uploaded photos. So he asks his mother, "What should I cook tonight, Mum?" And she answers, because the AI has been, the app has been fed with all her favorite recipes. There we are. There's something to think about. Nearly finished. Anybody here ever use ChatGPT? Millie, put your hand up. Okay. Or Perplexity, which is another one similar. So we are being challenged now about the gap between AI and human touch. I have to say that all the nurses in the room, and there are many of you, your jobs are safe. But I'm not so sure about the doctors. My favorite YouTube of all time, and the VR, the QR code will take you there, is a Texan pediatrician. And I heard him talk about 5 years ago, before we were all using AI, and he hopes that we will develop a superhuman stage of medicine. At the moment, we are being guided by tech. He thinks we will somehow put tech in its place and find out what only doctors and nurses can do. So this is a YouTube that I've watched several times and will inspire you. And I think that's it. And just really to say that everything we do locally, any innovation we do locally, we should be trying to scale it, because I don't believe we should all be reinventing the wheel. Thanks very much.